Hello, everyone, and thank you for attending today's webinar, The Promise and Challenges of WGS in a Hospital Setting, Overcoming Barriers and Increasing Access, presented by Genome Medical. I'm Rebecca Cushmiter, and I'll be moderating this webinar. I'd like to start off by introducing today's speakers. Brian Kermsey, Pediatric and Metabolic Geneticist and Chief Medical Officer at Genome Medical, and Jennifer Kaplan, Clinical Science Liaison at Genome Medical. You can read their full bios on the left side of your windows by selecting the Speakers tab. Just a few housekeeping notes before we begin. You can access closed captions from the bottom right corner of the video player. The webinar is being recorded. It will be available to watch on demand within 24 hours. And we'd love to hear from you. During the presentation, you can submit any questions you have using the Questions and Answers tab to the left side of your screen. Time permitting, we will conclude with a Q&A session. All right, let's go begin. Please go ahead.
Hello, everyone. Welcome. Thank you so much for joining this webinar on the promise and challenges of whole genome sequencing in pediatric care. In recent years, the benefit of genomic information to inform individualized patient care has continued to expand across multiple specialties in medicine. The cost of testing has decreased significantly. The ability to interpret genetic test results in a meaningful way has expanded greatly, and options for targeted therapies continue to expand. We know that timely access to genetic testing and genetics expertise can have a significant impact on patient outcomes in pediatrics. But despite this promise, many health systems find themselves currently lacking the necessary resources to fully embrace this growing need for genetics in patient care. So today we plan to discuss novel care delivery models for pediatric genetics that have been developed to overcome barriers and increase access to genetics care, specifically for pediatric patients. So I'm just figuring out how to forward. All right. So this is a high-level overview of today's agenda. We'll start today with a brief discussion of the promise of genomic medicine, both today and in the near future, and discuss some of the most significant challenges to implementation that exist today. We'll introduce the option of telehealth genetic services, and then take a look at some specific case studies of how different health systems have accessed genetics expertise via telehealth to build successful genetics programs within their institutions. And as Rebecca mentioned, our speakers today include myself, Jennifer Kaplan, and my co-presenter, Brian Kermsey. So Brian, I'll hand to you if you want to say hello and introduce yourself.
Sure, thanks, Jen. I'm Brian Kermsey. I'm a pediatric metabolic geneticist and chief medical officer at Genome Medical that was mentioned before, and I'm really excited to have this opportunity to talk about how we can and are using genomic medicine in pediatric healthcare.
And as I mentioned, I'm Jennifer Kaplan. Oh, sorry, Oh, that's okay. Go ahead, Brian.
I don't want to steal your thunder, Jen, please.
All right. No, I'll just really quickly. I'm a clinical science liaison at Genome Medical, as Rebecca mentioned, and I'm a clinical genetic counselor, was a clinical genetic counselor for many years, became involved at some point in the medical education surrounding the clinical implementation of new genetic technologies. And in my current role as clinical science liaison at Genome Medical, I work with our partners who are primarily health systems and laboratories and biopharma companies working on development of novel therapies. And I work with these partners to set up clinical genetics programs that meet the needs of the partners and our patients. Now over to you, Brian.
Excellent. So much exciting material to cover. I'm just trying to get on with the show. So, so we're going to turn our attention just to a case, basically. But I wanted to start with this quote, which I think is very illustrative and kind of captures the spirit of what we're talking about today. Nicola Blackwood is the chair of Genomics England, which is an organization that is at the forefront of genomic medicine in not only pediatrics, but also in general health at the National Health Service in England. And interesting, we at a meeting that was concerned with using genome sequencing in newborns and describing her own odyssey or journey with rare disease. she landed on this sentiment, which I thought was perfect and encapsulated what we're talking about. She said that it is infinitely preferable to be diagnosed with the disease you do have than to be diagnosed and treated for several that you don't. And so this was an encapsulation of precision medicine that I thought was perfect. And as I said, in the context of pediatric genome sequencing. So I thought we'd turn our attention at the beginning to a venue or to an area of the hospital or a health system where precision medicine is being used and the evidence shows is very important in the outcomes of children. And that's the neonatal intensive care unit, or the NICU, for most people know it by. And I was going to tell you a case of, it's a real case, and tell you a case of a little girl who was born in 2021, the second child to her parents, and at 3 days of age started to seize. She's developed very severe seizures very quickly in life. And obviously were brought to medical attention because she was still in the hospital at the time of their onset. And I just wanted to tell you how we ended up coming to the diagnosis, which is to say the traditional way. These seizures started, they were treated empirically with anti-epileptic drugs, but the question as to why these seizures were happening and why they were so severe was not answered for quite some time. Kind of the first round of investigation included, of course, MRI and EEG, but also the traditional newborn screen, which is done by biochemistry, was also sent and the results awaited. But since it only screens for 29 to 50 disorders, it came back negative without a diagnosis. So about a month into this child's hospitalizations, the seizures a little bit better under control, but not great, and the child was still having trouble. It was thought that maybe there was a genetic issue going on, which is a good thought to have. Genetics consult was obtained. But at that point, the only thing that was recommended by the geneticist who saw this patient was a karyotype, which is a traditional way of looking at chromosomes that we've had in our arsenal since the 1960s. So the chromosomes were done, and of course they were normal. And then a couple months after that, that's when I became involved in this particular case, and they asked me to consider a metabolic or mitochondrial genetic disorder, which I did, and we did find an unusual compound in her urine that started to point us in the direction. Now, alongside this entire clinical workup, luckily this patient, Hazel, we'll call her, was actually enrolled in a clinical research study at the hospital she was at, where whole genome sequencing was being done as an at the same time as clinical standard of care. And so it was right around the time that I became involved and that her research genome came back that they both converged on a diagnosis, which was an ultra rare metabolic disorder called combined DL2 hydroxyglutaric aciduria. None of you who are watching this today has to remember that particular phenotype, but just to know that it's an ultra rare disorder that probably wouldn't have gotten to unless the genome and the biochemistry had converged there. This disorder is usually caused by two pathogenic variants in a gene called SLC25A1. Again, over 22,000 human genes. Don't expect you to remember that either. But this gene encodes a mitochondrial citrate transporter. So very important insight into the biology of this particular patient's disease. So I promise this is not going to be a biochemistry lesson or a genetics lesson, but I wanted to give you an idea of how the traditional way of diagnosis for patients with severe phenotypes in the NICU usually go. And of course, what I didn't state, which is kind of the subtext of that last slide, is that Hazel's parents had to wait almost 5 months for a diagnosis, for clarity on what was going on with her, even though all along she's being treated for all of the complications of her illness. So what is possible today, and technically would have been possible a few years ago when she was born, but what is possible today is that we could have skipped ahead a great deal and had a patient with her severe seizures presented now, what we hope would have been offered her is a whole genome sequence very early in her course. So possibly at admission to the NICU, or possibly, around the same time as the newborn screen. So, and it is possible that the results of that could have been obtained within a week, and we would have gotten that diagnosis within a week of life instead of 5 months of life. And then once we got the genetic diagnosis of the mutations in SLC25A1, we could have reversed phenotyped with the biochemistry back into a diagnosis. So just again illustrating how this could have happened and contracted the diagnostic odyssey by months for this patient. And why is that important? Well, it turns out that with this particular patient, having that precise genetic diagnosis allowed us to connect with researchers both in Belgium and in Pittsburgh who were interested in this disorder, who were interested in therapeutics for this disorder. And over several months after that, we were able to come up with not only a treatment plan, but also novel therapeutics, an off-label use of an FDA-approved drug in particular, that actually in the long run ended up helping this patient's course. So this is the holy grail. This is the dream of precision genomic medicine in the NICU and in all pediatric illness, is that those who have a genetic disease get diagnosed with that genetic disease as early as possible so that we can intervene and hopefully make a difference in their outcome and health. So that's a case. Hopefully I didn't spend too much time dwelling on the particulars of that, but I hope you got an idea of where, and for many of you it may resonate, and you may recognize that diagnostic odyssey in the NICU. You may recognize whole genome sequencing and its place in the NICU, but for many, we'll see later, that's still a challenge. So why are we talking about using whole genome sequence in the pediatric population? Well, first, let's take a tiny step back and just think about genetic disease in a whole population, in any human population. And there's been a lot of epidemiology, genetic epidemiology, a lot of discussion about this, like what is the disease burden for monogenic disease, monogenic meaning, or monogenic meaning a disease where a change or a mutation in one gene causes the disease, determines the disease. What's the burden? And there's a range of things that you'll find in the literature, but the number that we've kind of converged on is around 5 to 8%. So I put 6% of the population has a significant monogenic disorder. When you kind of do the math on that, that's 20 million Americans. That's possibly up to a billion patients or people worldwide. These are not rare in total. When you consider all rare genetic disorders in total, these are not rare occurrences. And if you take even a further step back and consider genetically influenced disorders, like disorders that may have a major genetic driver but aren't determined exclusively by a gene or a genetic mutation, that number becomes more like 20 to 25% of people are affected there. And so again, not rare things. And then what I think is interesting for this talk is to consider, like, well, what is the genetic disease burden within a pediatric population? And we don't have great data on that, although every local genetics division has some insight into what that might be. But there's a paper from the early 2000s that I like to quote by Sean McCandless, who's now at the University of Colorado. But he looked at all hospital admissions at the hospital he was at back in the early 2000s, pediatric hospital admissions, I should say, and tried to determine whether or not the admission was directly related to a genetic disorder. And it was a very good paper and one of the first insights into the genetic disease burden within pediatric population. And the number he landed on was 34% of pediatric hospitalizations were related to patients who had a genetically determined disorder. So there's a big chunk of patients who are in a pediatric or a children's hospital who have a genetically determined disorder. So that's very interesting and of note. Then when we consider polygenic or multifactorial disorders, meaning disorders that have tiny genetic influences from different parts of the genome and maybe the environment as well, wow, it's probably every single human disease that we know of. But we're not considering those so much today, so we'll just put those on the back burner. And just to tell you that this group of disorders that we're calling rare genetic disorders, now there's a running list. It's called Online Mendelian Inheritance in Man, if anybody wants to go check the list. But it keeps track of how many have been described, and we're north of 7,000 now. So this is a very complex area of thought. So why now? Why do we want to use genetic sequencing or genomic medicine as a practice more in the pediatric environment? Why is now a good time? And there's a few lines of thought, but what makes it feasible, what makes it practical, is that just over the last decade or so, the time that it takes to get genetic data, i.e., a whole genome sequence, has plummeted. Obviously, everybody knows it took a decade to get the first draft of the human genome. And just a few years ago, it would take months, 6 months to get a human genome or even a human exome, which is related to the genome, just the protein coding bits of it. It would take months to get that information back, or that data, that test report. Now it is technically feasible or technically possible to get a genome back on a patient within hours if you're in the right place. So that's not a barrier anymore. Time and turnaround time is not a barrier anymore. It doesn't need to be a barrier anymore. And then cost. Of course, billions of dollars for the first draft of the genome. And now we can honestly do a human genome with reagents and labor for under $1,000. So now that cost is not becoming an issue anymore. And then on the right side of this slide, we see that the opportunities for diagnosing disorders, the 7,000 rare genetic disorders I mentioned before, is only going up. Remember, we have 22,000 genes, so a lot of room left for discovery there. And then the number 17 there with the blue line, the turquoise line, represents the number of FDA-approved therapies for genetically determined disorders. That's an important line, because that line, as you can see, is going up, and we suspect it's going to continue to go up. So linking patients to treatment starts with the correct, precise diagnosis. And for those of you who are not quite familiar with where we've been in terms of genetic testing over the last several decades, as I alluded to before, we started with the simple, humble, still very important karyotype, which is a picture of chromosomes. And then we've, through the 80s and 90s of the last century, we were able to kind of add genetic sequencing of single genes, a more precise look at human chromosomes through the chromosomal microarray, and then getting more and more clever at the turn of the century into the 21st century, we could put gene panels together that were kind of based on human phenotypes. So if you had a cardiomyopathy, a group of genes could be sequenced at once. If you had early onset Parkinson's disease, or you could consider a group of disorders. Those are just two random examples from my brain, but that's how we approach genetic testing for a long time. But it just became possible in the last decade or so that we could take a look at the entire genome at once. And the first step in that was whole exome sequencing, which I mentioned was when you look at the protein coding regions of the genome, which is a minority of the DNA that we have. Still some of the most important in terms of function, but minority. And now it is very possible to look at the whole genome sequence all at once, which gives us not only information about the spelling of the DNA, the genomic sequence, but also the architecture and the structure of DNA, much like the karyotype and chromosomal microarray can. So stepping back into the NICU, why would I want to use this technology in the NICU, and how or where should it be applied? And I would say that we have a good decade of data now that shows that probably most ill infants in the NICU should be offered whole genome sequencing as at least part of their workup for the reasons they're ill in the NICU. As you can see, this meta-analysis by Kingsmore et al. Showed or collected 31 whole genome or whole exome studies that were done in NICUs around the country, and when you consider all of those studies, the diagnostic hit rate converges on this number of about 35%, 36% is what I have here in the slide. That's really good hit rate. As a diagnostician, as a pediatrician, if there's a test that over a third of the time is going to get me an answer that will somehow contribute to my thinking and about a patient's symptoms and presentation, I think that's a really, really compelling reason to send that test. Also in this meta-analysis, there's some discussion about the definition of how precise diagnosis, genetic diagnosis changes management or changes outcome, and the numbers that are very conservative are that in these studies, about 27% of these diagnoses would change the actual management of the patient, and 19% would change the outcome. I think those are probably, if we redid these studies now, I think those numbers would be much, much higher, especially if you were to ask the parents and not just the bedside providers. There's also a cost effectiveness argument that's being increasingly made for whole genome sequencing in pediatric areas, not only the NICU and the pediatric intensive care units for older children, but also in the clinic and in the general wards of the general hospital. This is a study out of Canada showing a cost effectiveness for genome-wide sequencing or whole genome sequencing in patients with seizure disorders and neurodevelopmental disorders. We know that that's a very a good place to apply this technology. And then we'd be remiss if we didn't talk about, where we are in terms of implementing this idea or this technology in pediatric hospitals, or in particular the NICU. This is an interesting article, recent article out of, it's a multi-center effort, but I believe the authors are from the Children's Hospital of Philadelphia, who surveyed NICUs around the country, trying to understand how many of their NICU graduates, or those who are discharged from the NICU, actually had genetic testing as part of their workup or as part of their management while they were in the NICU. And surprisingly, it was just 13% of patients had at least one genetic test sent during their hospitalizations in this particular study. And as we've just seen, if you did genome sequencing on all sick infants, about a third of them are going to have a genetic disorder. So 13% seems a bit inadequate. And what's even more stunning is that depending on the hospital, the range of whether or not you got a genetic test was between 4 and 50% of patients. And so there's a lot of opportunity to harmonize how we approach or how we think about genetic testing in the NICU. So, and why is this? Why is there a shortfall, or why is this delta between what we know we should do, or what I know we should do, and what is being done? And I think there's three possible explanations. There's probably loads of explanations, but three major themes, which is, a lot of this genetic stuff has been relegated to, quite esoteric practice of medical genetics, which is what I do. And there just aren't enough of us. I think the last count, there's about 1,000 practicing geneticists, and some of them are in labs, not in the clinic or in the hospitals. And so there's just not enough of a workforce to go around to do these sorts of consults. We know the same thing is true for genetic counseling, like Jen's profession, in that even though we're minting more genetic counselors than medical geneticists, we're still not keeping pace with the demand and the number of patients that need expert genetic counseling. So, and then when you turn to the actual operational aspects of getting genetic testing done, all you have to do is be in a busy NICU and be asked to order a genetic test, and then get to the website for the genetic testing lab and realize that it's a 10-page form and consent, and there's a lot of check boxes, and it's a daunting task for the uninitiated. So, and not only that, but also the sending of the test and coordinating that with send out laboratory, and of course coordinating the pre-test counseling with the families can also prove to be operational challenge. And then, of course, when we're practicing in the United States, there's all these questions of, does my insurance cover this? Does my insurance not cover this? And will it cover it for this and not that? And what are the stipulations for coverage so I don't get a big bill? As I said before, the price of genetic sequencing and genome sequencing in particular is plummeting, but we're still not quite there yet. Certainly the payers are not quite there yet. So a lot of challenges that I think Jen is going to have fun sketching out some potential solutions for these issues.
Yep, that is what I hope to do next. Yes, absolutely. Thank you, Brian. So now that we've kind of provided an overview of some of the promise surrounding genomic medicine, as well as some of the challenges that are faced in the real world today, I'd like to just take a little step back and start thinking about an alternate care delivery model in genetics that can address some of these challenges that Brian just laid out. So to introduce you to Genome Medical, Genome Medical was founded in 2016 with the mission to expand access to genetic medicine to all. And one of the ways in which we aim to do that is to address some of these challenges that we've just outlined, right? So in 2024, Genome Medical is now the largest telehealth provider of clinical genetics in the US. We employ over 65 clinicians nationwide, and that includes genetic counselors as well as physician geneticists, many of whom were leaders in the field prior to joining Genome Medical. And on average, all of these providers have over 10 years of clinical experience. They're licensed in multiple states in which they provide care. And we currently provide over 5,000 genetic counseling patient appointments per month, and have delivered over 200,000 genetic counseling appointments in total. Our providers have expertise across many clinical specialties, including oncology, reproductive health, neurology, cardiology, pediatrics, and rare disease. And this mission to expand access to genomic medicine, it's supported by our novel technology, which has really been developed to allow our providers to operate at the top of their scope, allow us to scale care, and provide a user-friendly experience for both our patients and our partners. So how exactly do we do this? So we offer a variety of services when we partner with health systems, and at the core of what we provide is timely access to genetic counseling for patients. Our genetic counselors typically have availability within 1 week, which is pretty remarkable in the field of genetics. A lot of local in-person genetics providers have demand that far exceeds their availability, so wait times can be really quite long. We provide evening and weekend appointments for patients. Our genetic counselors meet virtually with patients, discuss their risk factors for genetic conditions, inform patients about genetic testing options, support decision-making, and then once testing is performed, we help patients and their providers to understand the implications of those test results to their care and make follow-up recommendations based on those results. We can also provide peer-to-peer consultations with our providers so that they can speak directly with patients' in-person providers at our partner health systems to discuss management of individual complex cases. And I do want to be quite clear about what we are exactly. We're an independent medical practice. We're not a laboratory. We are lab agnostic, meaning that we're not affiliated with any specific genetic testing laboratories. And as such, our providers can ensure that a medically appropriate test is selected from an appropriate laboratory in a given case and support ordering of that genetic testing as needed. So when we partner with a healthcare organization, we can utilize some or all of these services to kind of meet the organization where they're at and build a program that meets their unique needs. So in terms of pediatric genetics expertise, our providers have deep expertise amongst, across the team in various pediatric subspecialties, including neurology and endocrinology and neurology and others. And you'd see listed here some of the most common reasons for referral to genetics in a pediatric population, but this is by no means inclusive. It's just, these are the types of things that we tend to see most often. And as Dr. Crimsey alluded to, with this promise of these targeted technologies for genetic conditions really becoming more of a reality today and likely in the near future, the importance of establishing the underlying genetic cause of a child's condition is more important than ever. And that's true across multiple types of conditions in the pediatric population. And before I dig into a few case studies of how we've worked with health systems in the real world, I just wanted to take a quick look at a little bit of data. So this is essentially data about pediatric patients seen by Genome Medical over a 2-year period. And if you look at the little funnel there on the left, this describes how many patients were seen and tested. And ultimately, in about 21% of patients seen, that 47 patients down there at the bottom, testing was performed and a specific finding was identified that provided them with a specific genetic diagnosis and an explanation for their condition. But the most important thing for me on this slide that I really want to highlight is that number right in the middle, that 53%. And that number represents patients who were able to be seen by a telehealth genetic counseling provider, have genetic testing performed, and have a diagnosis and be resolved without an in-person medical genetics visit. And in-person medical genetics visits are critical for many patients, but as Dr. Crimsey explained, these providers, often the demand far exceeds their availability. And by being able to provide care to these patients with a telehealth model, it opens those providers up to have more availability, more time and resources for those patients that need it the most. And it also provides timely diagnosis and referral to specialists and care to these patients who otherwise might have to wait significant time to see a provider. So that leads me very nicely into our first case study. If I can forward the slide, there we go. So our first case study that we want to take a look at is focused on a pediatric teaching hospital, which serves a large surrounding rural area. This hospital houses the only genetic medicine clinic for many, many miles. They do have multiple physician geneticists and genetic counselors on staff. But at the time we started conversations with them, they were receiving about 50 genetics referrals per day. And the demand for services was so great that over time, they had built up a backlog of about 1,000 patients that were awaiting an appointment, and the wait times were around 6 to 12 months to see a provider. And on top of that, because of this large catchment area with this clinic, patients often had to travel quite significant distances to be seen. So this genetics team, frankly, knew they were a bit underwater, and they needed some support in order to provide the care that they really wanted to be able to provide for their patients. So in 2020, they partnered with Genome Medical to improve access to care for their patients. So prior to this partnership, as you see in this diagram over to the left in the slide, all of the patients referred to genetics were scheduled for an in-person appointment with a medical geneticist. And this was where the bottleneck was occurring, where that number of referrals began to exceed the availability of their geneticists. So what we did when we partnered with them is that we worked with their internal genetics team to develop new workflows where referrals could be triaged into different pathways based on the reason or indication for referral. So some indications were kept in-house and scheduled for those on-site visits with a medical geneticist. Some were scheduled first for an on-site visit with a genetic counselor, but others were referred to Genome Medical for a telehealth genetic consultation. And just to give you a sense of kind of how this played out for patients, I thought it might be helpful to take a look at a case study. So this is an example of a child that was referred to Genome Medical a little over a year ago via this partnership. And this was an 8-year-old boy. He had developmental delay and a recent clinical diagnosis of autism spectrum disorder. His mother had reported a full-term pregnancy, no complications. He had no dysmorphic features. His parents reported that he walked on time, he started talking on time, but when he started kindergarten, they noticed that he was developmentally behind his peers. And he was found to have delayed cognitive and motor skills. At the time of this visit, he was in special education at school, and he had been evaluated by neurology at age 6, and he had a normal EEG, normal brain MRI. He had genetic testing for Fragile X syndrome at that time, which was negative. So after meeting with the boy's parents and taking a family and medical history, the genetic counselor recommended chromosomal microarray for this little guy. And so when results came back a few weeks later, they indicated that this patient actually had a small deletion on chromosome 15, referred to as 15q11.2 deletion. And this essentially meant he was missing a series of genes on one copy of his chromosome. And this is a recurrent deletion in humans. It's been well described in a number of other individuals, and it is in fact associated with neurodevelopmental findings that were consistent with what this boy had. And what we also know about this condition is that some individuals do go on to develop seizures later in life. So the genetic counselor recommended that the family follow up with a local neurologist, and the counselor was able to speak to this couple about reproductive risk for potential future pregnancies if they were thinking about expanding their family as well. And long-term follow-up by a medical geneticist was not necessarily indicated. So this is a family who, excuse me, in other circumstances probably would have had to wait a year to have an in-person visit with a geneticist and have testing ordered. They'd probably have to travel a significant distance to have that appointment. And with this telehealth model, they were able to be seen in a much shorter time frame, achieve a diagnosis, and be referred on to appropriate specialists in a much more timely way. So this partnership with this children's hospital, we've now had ongoing for several years, and this just kind of shows the referral volume by quarter over the past several years. And you'll notice that the volume has varied quite significantly over time, and this is just based on natural fluctuations in their referral volume and staffing changes, things like that. So this has been another benefit of this partnership for the health system, is that as things change, Genome Medical has been able to flex with the number of referrals that we accept over time. So in summary, what we were able to do here, the initial focus of this program was to really work through that backlog and get those 1,000 patients in more quickly to receive the care that they needed. But over time, what we wanted to do too was to build a sustainable program that would avoid future backlogs and keep those wait times really low. So we were able to reduce wait time for a visit to less than 1 week, which was a significant improvement over the 6 to 12 month wait time that existed before that. And essentially over time, what we've done is, work with the team to kind of tweak and evolve that triage process for patients so that we can build a sustainable program for this health system moving forward. And to date, we've seen over 850 patients for genetic counseling through this program, and that number continues to grow. So moving on to another case study here. So this one's a little bit of a different situation. This health system did not have an internal genetics team. They had at one point, they had a geneticist, but she had retired at one point and they were unable to replace her, which is not surprising. That's the case in many health systems that we've spoken with, that as Dr. Crimsey alluded to, genetic specialists are in short supply. So the providers within the system, once this genetics program was disbanded, really were left with two options. They could either take on ordering and interpretation of genetic testing themselves, or they could refer outside the health system to a local genetics provider, but they also had very long wait times for appointments, and it was not a great experience for the patients or their providers. So they had originally reached out in 2018 because their cancer center had recognized the need for genetic counseling to test for hereditary cancer risk. But once that program was established, what we found was that other providers within the health system had learned about the program, and they began reaching out to the cancer center to inquire whether they could send their cardiology patient or their pediatric patient for genetics. So ultimately, over time, what we ended up doing was expanding this program to include multiple specialties and establish referral pathways directly from multiple different departments within the organization, so that, over time, all of these departments could access us in a more direct way. So again, a case example might be illustrative of kind of how this works in the absence of an internal genetics department. So this is another patient that was referred to us, and this patient was referred by his pediatric surgeon. He was a 2-year-old boy. He had congenital profound bilateral sensory neural deafness. And just to give a little history, he was full-term pregnancy, no significant complications or teratogenic exposures or maternal illnesses that might have resulted in his hearing loss. He had no dysmorphic features, but he did fail his newborn hearing screening. And at 2 years old, he didn't have any developmental delays. He had learned ASL or American Sign Language to communicate, and he was scheduled for cochlear implants in the coming weeks. But his provider felt it would be important to establish a genetic diagnosis. And there's many different genes that are associated with hearing loss. So it's usually not possible to really make an educated guess about what gene might be involved just based on a patient's clinical presentation. So what the genetic counselor ended up doing was ordering a panel of over 200 genes that have been associated with hearing loss. And so what ended up happening is that the results came back as potentially positive from the laboratory, which it's not exactly a straightforward result, and can pose some challenges to interpretation. And many causes of deafness are caused by an autosomal recessive pattern of inheritance, where a patient needs to inherit a pathogenic variant that knocks out function of that gene on one from mom and one from dad, so that they have no working copies of that gene. And what happened in this case was that he had a pathogenic variant in one copy of the MYO15A gene associated with deafness. And he also had a variant of unknown significance. So this was a change in the normal pattern of the gene, but one that we weren't really sure what it meant, whether it was pathogenic or not. So the genetic counselor ended up recommending family studies to help to clarify this diagnosis. And after looking at DNA from mom and dad, it did appear that this baby had inherited one of these findings from mom and one from dad, which was suggestive that this was probably the cause of his hearing loss, but not definitive, which was a bit unsatisfying. But what ends up happening sometimes with these variants of uncertain significance is that, as genetic evidence accumulates over time, these variants are able to be reclassified as either pathogenic or not pathogenic. And about a year later, the lab ended up reclassifying this variant as pathogenic. And ultimately, this boy had a diagnosis underlying his hearing loss. So it was a bit of a journey, but we chose this case to highlight that this can sometimes be a journey, and that it's important to have an ongoing partnership with a genetics team that can provide this follow-up care, follow-up recommendations, and deal with these sometimes less than straightforward results. And for this one, I think I might actually kick it to you, Brian, as well, to get your pediatric geneticist input.
Well, because we had this conversation when you showed me this slide, and the reason I love this case so much, Jen, is because a couple reasons. One is that when we're thinking about a healthcare system that has pediatric medicine within it, we oftentimes are thinking about the NICU, the PICU, and the pediatricians that have organ-based subspecialty training and that sort of thing. We sometimes forget about the surgical specialists who see pediatric patients, like ENT docs, or ear, nose, and throat docs, and ophthalmologists too. And in my experience, they're very well positioned to identify patients who might have a genetic diagnosis. Hearing loss is a perfect example of that. Eye diseases as well. And so having a partner for the surgical pediatric subspecialists within a health system makes a lot of sense to me. And of course, with hearing loss as well as eye disease, these are at the forefront of gene therapies and new targeted therapeutics for genetic disorders. So identifying a patient with non-syndromic hearing loss is no longer adequate. You need to know why, because it may be that that patient is, has a curative treatment available to them.
Yeah, absolutely. And yes, and moving forward, I think that will become ever more important as we have more and more of these targeted treatments. So similar to the graph that we showed during our previous case study, this just kind of gives a sense of the volume that we've seen via this partnership over the course of time. It's color-coded by specialty. So although the majority of patients from this health system continue to be referred for cancer-related indications, we see a significant proportion of pediatric patients as well as cardiology, neurology patients. And what we tend to do in situations like this is that we'll create kind of customized workflows and referral pathways for each specialty area within a health system. So for example, each pediatric subspecialty may want to refer their own patients and track their patients moving forward in our system. So we work with individual teams. We create custom workflows, establish primary clinical contacts for each team. And then once that patient has been referred, they meet with a genetic counselor, they have testing performed, and all of that clinical documentation, the visit summary, the test results, any recommendations regarding next steps, those are, of course, made available to the patient after the visit, but then also automatically provided back to the referring provider to kind of close that loop. They can be uploaded into the health system's EMR so that other providers within the health system all have access to that as well. So we're able to integrate pretty thoroughly with the health system. And just in summary here, over the course of this partnership, we've seen over 3,000 patients at this point across multiple specialties. We've had 50 plus genetic counselors interact with these patients. And I think this case study is just a really great example of how a health system with no internal genetics resources can really build a successful multi-specialty genetics program via kind of this telehealth model. So moving on to our final case study, I'd like to turn to the NICU. So in 2021, Genome Medical partnered with a pediatric nonprofit hospital, and what they wanted to do was implement a pilot program to offer rapid whole genome sequencing in the NICU, in that neonatal intensive care unit that we were talking about at the beginning of the presentation. They had limited internal genetics expertise to support this program. However, they had no medical geneticist on site, and they did want to offer genetic counseling to the parents of the critically ill infants in this study. So, just to take a little bit of a step back and look at the overall workflow in the NICU. So when critically ill infants are admitted to the NICU, the underlying cause of the condition is not always readily apparent, right? Many conditions are relatively nonspecific in their initial presentation. So traditional neonatology, which is diagrammed here at the top, it's been largely dependent on empirical treatment, right? While various tests are performed, as Brian described earlier, to gather more information, and then based on whether that patient is improving or worsening, the treatment may be modified, additional tests may be ordered, but this often leads to an extended diagnostic timeline, and it's, throughout this timeline, there's prolonged uncertainty for both the parents and the patient's providers. And historically, the turnaround time for genetic testing, such as whole genome sequencing, was weeks, if not months, and it really didn't lend itself to more of the day-to-day management in the NICU. But that is changing with the advent of rapid whole genome sequencing. So what this health system wanted to do was implement more of a precision neonatology approach, where they ordered rapid whole genome sequencing upon admission to the NICU. And they partnered with Genome Medical for this blue box here to provide that genetic counseling within 24 hours of admission to the patient's families. And the idea was that, if for those patients where a genetic diagnosis could be identified, they could really have a much better idea of prognosis and hopefully have better options for more targeted treatment for these very sick babies. So it keeps skipping ahead too. Sorry about that. I'm giving away the future there. So if we think back to this case example presented earlier, this is the same case that Dr. Kermsey discussed. It's really not difficult to comprehend the benefit of this genetic diagnosis within a few days, within a week, as opposed to 3 or 4 months later. And as genetic testing is really starting to be used more broadly, this is really going to become more and more important to have the specific underlying cause identified so that we can really treat in the most specific way possible. So, there have been multiple randomized controlled trials recently of rapid whole genome sequencing in the NICU. And I just wanted to highlight a few things that we've pulled out from some of these studies. So up at the top there, those top bars indicate that physicians overall said that results had clinical utility. And this is whether whole genome sequencing yielded a positive result in a genetic diagnosis or if it yielded a negative result, right? That physicians felt that either way, these results were clinically useful. And the majority of physicians reported a change in management based on a positive test result. But interestingly, 16% also reported a change in management based on a negative test result, right? Because if genetic etiologies can be, ruled out, or at least the likelihood significantly reduced, then those physicians could focus on other things other than the possibility of these genetic conditions. And what I find really most remarkable here is this bottom line where the parents of these very sick kids said that the results were useful and not only benefited the child, but benefited the parents and the whole family. And that was really across the board, 100% of patients with positive results and 96% of patients with negative results. The parents felt this was a really, really useful finding and result for their families. And I think this is critical. I mean, one of the early concerns that was voiced when rapid whole genome sequencing was proposed in the NICU was that these parents were kind of in this very anxious place, would be unable to provide informed consent, that the whole process would cause anxiety and just be upsetting for parents. But that's really not what we see. Excuse me. So throughout the course of this pilot study with this particular NICU, Genome Medical was able to provide genetic counseling to the parents of 18 of these critically ill babies. And of those that consented to the use of their data for research, 5 of these babies had pathogenic findings identified, which provided a specific diagnosis for that child that could inform treatment. We were able to provide genetic counseling to these families within 24 hours of admission to the NICU, and 94% of families who were referred did end up utilizing the service, which really demonstrates the interest of these families and the need for these services. So in these 3 case studies, we've focused largely on the delivery of services to patients, but we also want to spend just a moment to talk about our peer-to-peer consultation service as well. So I might hand that one back over to you, Brian.
Absolutely. Thanks, Jen. That was a great presentation, hearing those cases again. So as Jen mentioned, a lot of what Genome Medical does is provide the actual genetic counseling through board-certified genetic counselors. But we do have a team of medical doctors as well, MDs, some of whom are, like myself, board-certified geneticists. And sometimes, especially in settings like the NICU, not only is genetic counseling important, but also sometimes having expertise, somebody who's trained in pediatrics as well as genetics, to have conversations to kind of work through diagnostic algorithms, testing strategies, and even management type things in a peer-to-peer sort of way. This isn't direct patient care by the geneticist, because our team is small right now, but this is a service that we find a lot of pediatricians are open to, as having the ability to talk to one of us. So I think in combination between genetic counseling and medical geneticist expertise, it's a bit more of that team medicine that Jen has been describing with all the case studies that she's given us. So I think, we'll wrap up here with a few takeaways, which, none of which will surprise any of you who've stuck with us thus far. But what we're basically saying is that a precise genetic diagnosis is increasingly becoming not an option for sick sick children, especially critically ill children in the ICUs. And it's possible now. So we should be thinking about it and how to operationalize it in our pediatric health systems. And one of the reasons for that, number two, is that there's a growing number of FDA-approved treatments for rare genetic disorders, and you can't link a patient to a treatment without a diagnosis first. So getting in there early and figuring out whether or not they have a genetic diagnosis is important. We also know that because of a lack of providers, as well as a lack of internal resources sometimes within health systems, that these present operational challenges. But then I hope we've also shown you that there are some clever and novel ways and care delivery platforms and care delivery models that can help alleviate some of these operational concerns so that we can all work towards harmonizing our approach towards genomic medicine in pediatric populations in the future. So thank you all for sticking with us. And I think we're going to have a few minutes for questions. But if for some reason it looks like we may run out of time, which we will, and you have any further questions, you can put them in the chat, or you can contact us at askus@genomedical.com. We're happy to get back to you with answers.
All right, let's go ahead and move on to the Q&A. I can see we've got some questions in the box already. Let's get started. We already do newborn screening. Why do we need WGS, and what's the difference?
Do you mind if I take that, Jen?
Yeah, absolutely. Go right ahead.
Okay. Only because newborn screening is near and dear to my heart and has been what I've been doing for the past 18 years of my career. So traditional newborn screening, which started in the 1960s with a single disorder, PKU, is now a public health program in all 50 states and most of the other countries with the developed healthcare systems. But the panel of tests that are tested for now number anywhere between 20 and 50 disorders. So a small, important group of disorders, but not the potential number of disorders that whole genome sequencing can uncover. Which, depending on who you talk to, can be anywhere between 500 and a few thousand different pediatric onset disorders, depending on how you want to set the level or threshold of detection. So the other important and somewhat obvious difference is that traditional newborn screening is a screen based on biomarkers, on biochemicals in newborn blood. Whereas what we're talking about with whole genome sequencing is actual sequencing the DNA, the genes of a newborn. Also, what we've been talking about today is applying this technology to the sick or ill infant, the child who presents with symptoms. And that's a bit different than a universal screening program of newborns, which endeavors to provide a screening test to all comers, so all children born, whether they're sick or well. And that is a bigger question and it's an interesting question, but one that we'll have to answer in time. We'd like to get the sick kids taken care of first.
All right, our next question, and we may be coming to the end of our time here. Who pays for these services, the patient or the hospital?
Another good question. I can take this one if you don't mind, Brian.
Absolutely.
So Genome Medical contracts directly with health systems, and we have a few different pricing options. I'll start to say that we are a medical practice who is an in-network provider with many insurers, over 130 million covered lives, I think we're at this point. We're in network with a lot of the major payers such as Aetna and United and Cigna. So we do offer an insurance-first model. So for those patients who are in network, we can bill the patient's insurance directly for our services. For those patients who are out of network, and that does include Medicaid, Medicare, those can be covered either by the hospital if the hospital chooses to do that, or it can be patient self-pay as well. So we have multiple payment options. Of course, I should note that for inpatient settings such as the NICU, those need to be institution billed. And I do always like to point out too that, when we talk about cost for our services, it is the services for the genetic counseling and the clinical interactions with patients. Genetic testing is billed separately by the laboratory.
All right. Well, thank you so much. This is the end of our time here today, and I'd like to thank everyone who submitted questions. If we weren't able to get to yours, we will try and get back to you individually after the webinar. Thank you all for attending this Fierce Healthcare webinar and submitting so many great questions. I'd like to thank our speakers for participating and Genome Medical for presenting today's webinar. A recorded version of this webinar will be available to you on demand within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.